Good afternoon, everyone. Here I am presenting a case of bilateral peripheral ulcerative keratitis. I have no financial interest. Case history: a 60-year-old male patient, former patient, came to IOPD with complaint of foreign body sensation 1 month, redness, eye pain, and photophobia since 20 days. History of presenting illness: the patient was apparently well 1 month back, then he started experiencing foreign body sensation in left eye following an injury with tree branch. And for the last 20 days, he complained of redness, eye pain, photophobia from both the eye. There is no significant past ocular and medical history, and family history, no significant ocular disease. In general examination, findings are all well within the normal limit. Patient was well oriented to time, place, and person. In ocular examination, the patient's best corrected visual acuity in right eye is 6/24, and in left eye is 6/36. Pupils are central, round, and reactive in both eyes. Extraocular movement and IOP are within normal limit. Slit lamp examination. This is the slit lamp photograph of right eye in diffuse light illumination. All findings are within normal limit, except in peripheral cornea, there is 4 o'clock to 6 o'clock position. There is a crescent-shaped ulceration present, although central cornea is clear. This is the slit lamp photograph of left eye in diffuse light illumination. Here conjunctival congestion as well as circumciliary congestion present. Central cornea is clear, but at 4 o'clock to 10 o'clock position in peripheral cornea, there is crescent-shaped ulceration present with corneal thinning also present. Coming to the provisional diagnosis, this is the case of bilateral peripheral ulcerative keratitis with corneal thinning in left eye. In diagnostic workup, first of all, comprehensive systemic review to rule out systemic disease associated with PUK. The three most important diseases are rheumatoid arthritis, Wegener's granulomatosis, and SLE. A complete ophthalmic examination to exclude local pathology. Corneal scraping was done and subject to gram mount, gram staining, KOH mount, and microbiological examination. In this particular case, blood culture shows staph growth. In lab investigation, complete hemogram, ESR, CRP, CNK, and PNK or urine analysis was done. Blood investigation came negative. Patient was advised for rheumatologist clearance for systemic immunotherapy. Differential diagnosis includes Murren's ulcer, Tadian's marginal degeneration, pellucid marginal degeneration, and keratoconjunctivitis sicca. For treatment, patient was started with oral prednisolone 1 mg per kg body weight, tablet doxycycline 100 mg BD, eye drop moxifloxacin lotepred 4 times a day, eye drop cyclosporin 0.5% BD, and eye lubricant and cycloplegics are also added. This is the slit lamp photograph of left eye after follow-up of after 3 months of regular follow-up. In this photograph, we can see that inflammation was under control and ulcer is in healing stage. So PUK is a rare inflammatory condition of eye which affects the juxtalimbal cornea, and it classically presents with the ulceration of peripheral cornea, epithelial defect, and stromal lysis. Can be the first presenting feature of a life-threatening systemic disease, and it can be associated with autoimmune disease, among which 50% is associated with collagen vascular disease. Coming to the pathophysiology, any inflammatory stimulus in peripheral cornea results in immune complex deposition in limbal vessels, which causes complement activation and which leads to chemotaxis of neutrophils and macrophages. These inflammatory mediators causes release of collagens, metallic metalloproteinases from keratocytes, which causes destruction of stromal causes and corneal ulceration and thinning. So to conclude, prompt management of PUK is to reduce motility and morbidity, and primary goal is to promote epithelial healing, stop stromal lysis by controlling inflammation, and prevent the superinfection. Thank you.
Thank you, Neha. That was a well-presented case. So we'll move on to the next presenter, Dr. Priyanka Bharti. In the meanwhile, we're having help with the audio-visual.
You can take some comments for Neha's case. So the last few slides we couldn't see, but
Yeah.
we got most of the
Yes.
We could see is bilateral switching. let me.
What about the cyclosporine that you have used? It is BAC free, preservative free. Okay, now it is available. Cyclase from Intas, that is preservative free.
Point, 0.05.
0.5% she is saying. 0.05. Okay, okay.
That is a good case, Neha. I think that it was a very, it was not as severe as some of the cases that we see with PUK. So that way, right, right. So in PUK, when you have immune mediated, meaning there's no infection, it's not a pseudo PUK, then there are only two kinds of entities. One is if you have Moran's ulcer, which has its own classical peripheral overhang edge, etc., etc. And the second is you have sort of a non-specific, but maybe immune mediated. So yours was in the second stage. This one, the second kind, this usually has a better prognosis. So as you treated very correctly, you examined and you did some investigation for the patient, and then you treated the patient with steroids, and the condition resolved. So let's just keep our fingers crossed that the patient doesn't keep coming back to you. Then there are many other conditions, which not many other, but a few other, which look like PUK. So you can have marginal keratitis due to various other causes, staph, lid issue, or you can have due to herpes and so on. So that you try to rule out. But my point about the entire way which most of the ophthalmologists, and including cornea specialists, look at PUK is that the minute the patient comes, you do a workup, a systemic workup. Systemic workup has no role, except if you see a kind of a PUK which matches a pattern of rheumatological disease. There are just basically about two rheumatological diseases that can have PUK. One is rheumatoid arthritis. The other one is GPA or vaginal granulomatosis. Yeah. And that patient could come to us first, frankly speaking, without much of systemic problems. So apart from that, if you do a lot of investigations, you'll get something positive. Then you'll start chasing that something positive. Let's say Mantel's test and things like that. So what I would suggest to the group is not to investigate the patient too much, because there aren't any biomarkers. There aren't any absolute biomarkers. If this is positive, then this patient has this disease. But after a point, stop focusing on investigation and then you treat these patients as you correctly did.
And long follow-up is required in such, because recurrence can be there.
And is Dr. Saranya here? Dr. Saranya, I really appreciate, because immunocompromised, bad ocular surface.
We are going back to discussing your case, which we were supposed to do in the end, but
since all these and also fungus in an immunocompromised and damaged ocular surface, very tough to handle, but the results were very good. So I appreciate. But then she discussed nearly 30 to 40% of OSSN case would have HIV. That's up. Do you have any data to support this?
so you can just speak loudly.
It was found in a case series where 60 patients had been examined. 60 patients with OSS and experienced HIV. And out of that, out of 60 people, 40% of patients were found with positive. It was a case series.
So HIV as a disease has gone down a lot, luckily, and also OSSN is much more prevalent than we think it is, and it's not associated only with immunocompromised individuals. Even immunocompetent individuals develop OSS. So that's an old data. If you read papers which have large series now of late, there is a prevalence of some immunocompromised conditions and other virus association, systemic association, but not as much as you pointed out. So no longer is that entity that
it's almost strong. 1 out of 3 or 1 out of 2, what you say.
Yeah.
2 cases of OSS and 1 is HIV positive.
That is the older literature. So do you know Murphy's law? It says that if something has to go wrong, it will go wrong. And under Murphy's law, there are 4 laws. One of it says that if something has to go wrong, everything possible will go wrong with it. So this reminded me of that. So the patient had 2 disease in the eye and then also a systemic disease. So sheer bad luck, but it was managed well.
And Dr. Pranita, about the new terminology of conjunctival geographic. It makes sense, but there are so many other differential entities.
Yes, sir.
It need not be herpetic keratitis. But in your case, did you do a PCR or?
So we did not do, I actually planned to do a PCR testing, but the dramatic response it showed within 1 day of starting antivirals and complete resolution by day 3. So I did not think it was necessary to go on to
So it's
PCR
just a
testing.
presumed diagnosis.
Yes,
I
it's a
wouldn't tell
presumed
it's.
diagnosis.
Patient responded instantaneously, then you started the antiviral.
No, sir, we started antiviral day 1. There were resolution of symptoms, that
Okay.
is, it had started to go down almost 30-40% decrease in the epi defect, and by day 3, 72 hours, the conjunctival ulcers and the small dendrites, they also resolved.
Okay. Okay.
So sensations, the patient was already so photophobic and watering and red. We did check the sensations, it appeared to be normal. It was not reduced. But yeah, it is. But in all patients, we cannot have reduced sensations also.
So, I think that Pranita made a very convincing case for herpetic disease, and we have seen similar such cases. Although it's little hard to prove, but only when you had corneal manifestation as well, so
Yes.
that made it very clear.
Yes, ma'am.
And we didn't, in those patients, we didn't start therapy till we saw the corneal lesions.
Yes.
And once you start corneal lesions, you have dramatic improvement.
Yes.
So if it's only conjunctival, you may not have any change in the corneal sensation. Only when it's corneal involvement, then you'll have a change, decrease.
Also, PCR is not available at every
Everywhere.
place.
We tried to find a lot of labs. They were not willing to do it. They did not have the facility.
Yeah.
So I had to start treatment anyways.
Yeah, it's available at most of the institutes and
Yes.
big centers only.
And even there, the reports won't be available for next 3-4 days for the final reporting.
Serology, IgM.
IgG,
I did
IgM.
not, I did not go for that.
Okay.
PCR is negative, which it can be, and you have a
dendrite.
dendrite. So would you even regard PCR in that case? So I think it's pretty much a clinical diagnosis, and I wouldn't do any test for these.
And conjunctival geographic ulcers have also been previously reported with herpetic infections. So I searched the literature. There were 3-4 case reports which reported conjunctival geographic ulcers.
No doubt. If cornea can have such a
Yes.
conjunctiva still,
Definitely.
because they are near coastal.
Sure.
But there are a lot of other things.
Yeah.
Even bigard extra what you
Yeah,
could have
that could
caused-
have caused it.